This is a special session that will really give you a very clear understanding of the current state and future directions of transcatheter valve therapy. And I call it the K&K show. This is Kodali and Carr that are going to be taking over this afternoon. So I'm going to be very interested to learn something, and hopefully this will be useful to you in the audience who are going to be quickly gaining familiarity with these therapies. Our first speaker is Susheel Kodali, of course, one of the co-directors of the meeting, and he's also the co-director of our Columbia Valve Center, and he's going to give us a thorough discussion of the Edwards Sapien valve, including the XT.
Great. Thank you, Marty. So we're going to move forward in the interest of time. We saw a live case with the Medtronic core valve, and we saw some of the discussions that happened this morning. The Edwards Sapien valve is the balloon expandable version of a transcatheter valve. The Edwards Sapien valve right now is only available in the U.S. It's the first generation device, and outside the U.S. everyone has moved on to the next generation. But basically it's a stainless steel stent. It's a balloon expandable frame. It is bovine pericardial tissue, and the valve is either 14 or 16 millimeters in height. And the next generation device is the Sapien XT. The frame is cobalt chromium instead of stainless steel. The leaflets are cut differently, and there's additional sizes available. But one of the big differences in terms of the clinical results for the patients is that this device goes through a 22 or 24 French sheath, which is either a little over 8 or 9 millimeters in size, but this device goes through a 18 French sheath or 19 French sheath, and now is down to a 16 French expandable sheath. So the device is much smaller and much more accessible for patients in terms of the iliacs. This is just a brief animation of the procedure, and what you have here, the sheath is placed retrograde from the transfemoral approach. It's done percutaneously without cut down. The device is advanced up under fluoroscopy. The valve is a system of docking the valve onto the balloon. It's done in the body in the descending thoracic aorta under fluoroscopic visualization. The device is then tracked around the arch under fluoroscopy, and it's positioned across the native valve. And this device only works for aortic stenosis and not aortic regurgitation. And unlike the core valve case this morning, we need rapid pacing to knock out cardiac output during valve deployment. And so rapid pacing is initiated when the valve position is good, and the balloon is inflated and deflated over a period of 5 to 10 seconds. And the system is removed, and the valve anchors in the native leaflet calcium, and so the rest of the catheters are removed, and the arteriotomy in the groin is closed, either percutaneously or surgically. That's ideal. As I said, the device with the XT is now 16 or 18 French, but there are still patients that don't have access due to severe peripheral vascular disease and calcification in the iliacs. So they're all, obviously, if we can go transfemoral, we prefer it, but outside of that, there are other options, such as ilio-aortic conduits, and two other approaches, the transapical, which goes through a small lateral thoracotomy, or the transaortic, which goes through a small upper thoracotomy. These procedures are essentially the same device, same catheter, but they're put directly into the LV or directly into the aorta and avoids the peripheral vasculature in patients that have significant vascular disease. So what's required? And we talked a little bit about it this morning during the live case, so I won't spend as much time. But really, pre-procedural screening is what's crucial for a successful procedure. And that includes screening of the aortic valve anatomy, including the aortic valve, its relation to the coronaries and the surrounding structures, as well as vascular access, to make sure you have adequate access to go from the groin. In terms of in the procedure itself, a hybrid operating room is required, which requires a sterile environment with advanced imaging capability. And as we saw the importance of this morning, you need the capability to manage complications either surgically or with endovascular techniques. You need to have the capability to go on cardiopulmonary bypass if there's a catastrophic complication. And it really requires the integration of the entire heart team. And we talk about this a lot, and that's the surgeons, the interventional cardiologists, the echocardiographers, as well as all of the ancillary staff. In terms of the screening for the vasculature, the reason it's important, as I said, the device that's available in the U.S. is either 22 or 24 French ID, which means an outer diameter of 8 or 9 millimeters. The next generation device, which is smaller, is still anywhere from 16 to 20 French when it goes into the patient. And so it's important to screen the vasculature, and really the gold standard is a CTA. These are the typical reconstructions we do when we measure vessel size very carefully up and down. Then we also need to screen the aortic valve complex closely, because you need the valve now. With the next generation device, there are 3 sizes available: a 23, a 26, and a 29. These will accommodate annuluses from 18 to 28. And we need to measure the annulus carefully. And in the beginning, we used to take one single measurement on TE, but we quickly realized that the aortic valve complex is really a 3-dimensional structure, and it's not always round. And you need the 3D echo capability to make these measurements in a reliable fashion. And that's really where 3D TE has really made a difference. And we use 3D TE to measure, as they mentioned this morning, areas, perimeters, and to get a real good understanding of the 3D anatomy of the aortic annulus. And that's crucial for procedural success. In addition, on echo and CT, we evaluate the entire complex: annulus to the left main distance, sinus height, sinus calcification, because all of these play a role in potential complications. And you really need to define the anatomy of the entire landing zone and the adjacent structures. And that can be done with 3D echo, or, as is often simpler, multi-slice CTAs with reconstructions. And this is simpler because it's less operator dependent, and you can get all of the key measurements. So now, let's just assume that just a quick video of the procedure itself. This is the device being advanced from the groin here, and you see the device in the descending aorta. Oops, sorry, I paused it there. And it's being tracked around the arch. And the catheter flexes to try and avoid trauma to the aorta. This is the device that's available in the US, and I said that's the first generation device. The valve is then crossed, the native valve is crossed, and it's positioned across the diseased valve. And you confirm on both echo, as you see here, and on fluoroscopy, you confirm that the valve is 50-50 with the native aortic annulus. And you see echo here nicely, and you see on fluoroscopy. Then during rapid pacing, and this is the aortic tracing here, as pressure drops, the balloon is inflated and the valve is deployed. And so the valve is not retrievable, so you get a single shot. After the valve is deployed, you do a careful echocardiographic assessment of any potential complications, and you can use 3D echo for that as well. So that's a brief overview of the procedure. I want to go quickly in 5 minutes over some of the results that are available. You know, the Edwards program has gone from numerous studies from first in man to feasibility to the partner trial, which was the randomized controlled US trial, to multiple post-market trials in both Europe, Asia, and as well. I want to focus on the partner randomized trial, which Marty Leon and Craig Smith at Columbia were the PIs. And this trial had 2 arms. The first arm were patients who were high risk, and they were randomized 1-to-1 between transcatheter valve through either the groin or through a transapical approach versus conventional surgery. And these were patients that had a surgical risk of at least 10 to 15%. The second arm was patients who were deemed inoperable, too high risk for surgery, and they were randomized between medical therapy and transcatheter valve through the groin. When you look at the inoperable arm, this is one of the most dramatic, this is Kaplan-Meier curve for survival. At 1 year, there was a 20% difference in survival between patients managed medically and those that received a transcatheter valve. This difference continued to separate between year 1 and 2, such that at 2 years, you needed to treat 4 patients to save 1 life. So this is a dramatic improvement in mortality. There's also a dramatic improvement and decrease in repeat hospitalizations, and the number of days alive outside the hospital was double in patients that were treated with the transcatheter valve versus medical therapy. In addition, there was a quality of life study, and there was a significant improvement in quality of life in patients that were treated with a transcatheter valve compared to medical therapy. These are dramatic improvements. When you look at the other arm, which was patients that were randomized to surgery or transcatheter valve, this was a non-inferiority trial. And there was no difference in mortality at 1 or 2 years between transcatheter valve and surgery, which was statistically significant. when you looked at the quality of life survey, there was dramatic improvements in both the transcatheter valve arm and the surgical arm. The issue was the patients with the transcatheter valve, especially those done transfemorally, recovered more quickly and improved more quickly, but by 6 months there was no difference between the two groups. And when you looked at the subgroup patients that went through the groin versus surgery, the number of days in the hospital was about 6 days less. Number of days in the ICU was about over 2 days less. So these were patients that had a much shorter hospital stay. These were patients that were very sick, but they recovered more quickly and they got out of the hospital more quickly. This is less relevant in India, but in US dollars, transfemoral valve replacement was cost-effective compared to surgical AVR in these high-risk patients. The transapical did not show the same benefit, but this was a much smaller study, and this was an early learning curve experience. That was the U.S. experience. When you looked at the Canadian registry, the mortalities at 1 and 2 years were about the same with transcatheter valve. These were not randomized trials. The partner trial is the only randomized trial that has presented data compared to transcatheter valve and surgery. The Medtronic randomized trial is ongoing. In addition to the registries in Canada, there were 2 registries in Europe. The first was the SOURCE registry, which were patients that were high risk, and these patients were consecutively enrolled at multiple centers. There wasn't a core lab, but events were adjudicated by the primary investigators. And when you looked at 1 and 2 year survivals, you see about the same. As a pooled group, 1 year survival was about 77%, which is similar to what was seen in the Canadian as well as the partner trial. The SOURCE XT registry uses the next generation device, which I talked about earlier, and this is the cobalt chromium stent, which is a smaller introducer. And when you looked at these studies, this study had adjudicated endpoints by independent and an echo core lab. The majority of procedures were done transfemoral, and there was an elderly patient population. The transapical group in general was a higher risk cohort. When you looked at the survival again, the all-cause mortality was 4.3% in the transfemoral, 10% in the transapical. And again, the transapical had a higher percentage of patients with high Euroscore, so it was a sicker patient population, and those with the high Euroscore did very poorly with a 22% mortality. The French registry I'll skip over, but again, the results were sort of similar. Outside of the mortality, the main adverse events, one of the ones that was focused on a lot is stroke. In the partner trial, which was carefully adjudicated, the stroke rates in the surgical arm were about half those in the transcatheter arm. But most of this was by this early procedural risk. After the 30-day procedural risk, there was no difference in stroke between transcatheter valve and surgery. And these strokes occur because you have embolic events when you're putting this valve in, because you're manipulating this diseased native valve. And this is the filters. There's filters that are available that aren't yet approved, but they caught some of this embolic material. And the other major complication we worry about is paravalvular leak, and a lot of this is based on valve sizing. If you don't appropriately size the valve, you get these gaps and you get leak. In the partner trial, about 10% of patients had at least mild or more paravalvular leak. And that's seen pretty similar in most other studies. What was different about the partner trial is when you looked at these patients that had leak, even the presence of mild leak increased long-term mortality. And that's an important thing to note. The other 2 major complications that were procedure-related were vascular and bleeding complications. And they were about anywhere from 10 to 15%. And most of them are dissections or perforations. And the reason it's important is when you had a major vascular or a major bleeding event in transcatheter valve, it dramatically increased mortality. So this is a quick overview of the data, but basically transcatheter valve can be performed with acceptable 30-day mortalities of between 4 and 5%. The main complications remain stroke, which has a frequency of about 5%, major stroke about 2.5%, and paravalvular leak, with a moderate paravalvular leak present in 10 to 12% of patients. Next generation devices will need to address these limitations. Thank you very much.